Welcome back to the Catalyst Pharmacy Podcast. Today we had Benjamin Jolley with Jolley's Compounding Pharmacy on. Also, he's got a consulting arm of his business, works with HingePoint as well on some patient messaging pieces. But he just wrapped up a project around pharmacy closures that he's going to talk through a little bit. Just so much good information that, and his opinion and his takes on just kind of state of the world, incentives, alignment, and what we could do in the future. So we'll take you there now. I wanted to talk about a little bit. We can transition over to the
sure.
You just got through with the project. I'm gonna let you describe what you did, but also like sprinkle in too, like why you did it, what you're doing with it, and go from there. And if you don't follow Benjamin Jolley, we'll drop all of that in the show notes for everybody if you haven't yet. But you just got through with the really pretty daunting, arduous journey for a project. Let's talk through it.
Yeah. So I guess let's start with the context here. So pharmacy advocacy groups on both the pharmacy side and the PBM side constantly argue about how many pharmacies there are, how many independent pharmacies there are they closing, are they opening, are there, who's right, who's wrong, is pharmacy in a good space, is it a good business to invest in, are the PBMs stealing all of the money or not? Like this is a constant back and forth every year. Who like the PBMs will hire some top shelf company to say this is the NCPA's numbers are totally wrong and there are lots more pharmacies and yada yada yada. So I decided to take matters into my own hands, I guess, and just do an analysis of the data myself. So I took a list of every pharmacy that was open January 1, community pharmacies,
right? Okay.
Not long-term care, not mail order, whatever. Community pharmacies. This includes chain pharmacies that are open on the first of the year, and then that were open on September 1st. Compared the two, we actually started this with people that were open on August 1st, and then we added in the change from August 1st to September 1st.
Okay.
But anyway, so took this list of how many pharmacies are there, and then said, okay, all of these pharmacies, their NPI numbers are no longer legit. They're no longer there. And so what has happened? Did they close? Did they change ownership to someone else? What's going on here? And so we categorized all of these pharmacies by. I started with just the assumption that chain pharmacy headquarters know which pharmacies have closed, and they don't just randomly get new NPI numbers.
Right.
I think that's a fair.
I think that's a fair assumption. Right. Yeah.
Like that CVS manages their database appropriately, manages their NPI numbers appropriately. Like that seems like a fair assessment. So I just said, okay, these pharmacies are closed. They're chains that have closed. So took those, moved them out. And anyway, the numbers we started with, I think, was 2,500-ish pharmacy locations, maybe 2,600. Anyway, somewhere in that neighborhood of locations that had either closed or changed ownership. And anyway, so went through all of the remaining non-chain pharmacies and said, okay, what publicly available information can we find about these folks? Is their Google profile just listed as permanently closed? Does their website say anything about them closing? Is there a news story about it? And got through a large batch of pharmacies that way. And then the remaining ones just took a long time of elbow grease, to use your words, and just called several hundred pharmacies, probably about 600 pharmacies.
Oh, wow.
and said, "Are you still open? Are you still open?" A lot of them, it was just numbers disconnected. So I figure if your number is disconnected, you're closed.
Yeah.
If the number that's on your NPI record is disconnected, that's a pretty good indicator that you're probably closed. Some of them we would get, an IVR message that says, as of September 2nd, Main Street Drug is closed, or whatever. And your records have been transferred to Walgreens at this at this address. And then, a few times people would answer the phone and we'd say, "Hey, we're just seeing if you are still open. Are you still at this location?" And most of the time, when I actually got through to a live person, the answer would be, "Yeah, we're still open, but maybe the name had changed or maybe the ownership had changed." Right. So they just had obtained new...
So normally someone picking up the phone's a good indicator of a change of ownership.
It's a good indicator.
Yeah.
Some of the time it would be, no, that location is closed. We bought their records and their phone number.
So you're forwarding the phone number.
Forwarded their phone to a new person.
Right.
Anyway, so after going through all of this, the 2,600 pharmacies that we started with, 2,275 pharmacies was the number we ended up with that have closed since the first of the year.
2,275, you said? That includes chain, independent, community, small regional chain, you name it. Basically, community segment.
Right.
That's a lot.
It is a lot.
Yeah.
It's a lot. I mean, the numbers we started with was that there's somewhere around 60,000 pharmacies in the country.
Mm-hmm.
So 2,275 closing out of 60,000. That's a big fraction.
Yeah.
It's
basically 5% of the...
Yeah. So, somewhere just north of 4, less than 5% of all pharmacy locations. There have been pharmacies that have opened in the same time frame, but it's a lot less than the number that have closed. So on net, something like 3% of all pharmacy locations in the country have closed.
So on net? Okay. Wow.
Yeah.
All right.
And I don't really like the concept of like netting out, because like one guy closing is not offset by some other new sucker coming into the business and opening, because they're probably not in the same location.
Right.
It's not
apples for apples. Like if you talk about
right.
like just patient access, it's really not apples to apples from an access perspective for sure.
Right.
You need
like if you have a rural location closed and you have an urban location open, those are two very different
100%
situations.
Yeah.
Additionally, looking at the pharmacies that opened, a really big fraction appear to be owned by 340B covered entities, dish hospitals, Ryan White clinics, federally qualified health centers. And so, like, especially if you're saying, okay, this many pharmacies have closed, they were mom and pop shops. They were replaced by these pharmacies that are owned by a hospital system. Those are different levels of pharmacist independence, different levels of sophistication of the business, different levels of, are they necessarily a target market for Pioneer? They might be.
Maybe. I don't honestly don't know.
I don't know. I mean, I know some clinics do use you guys.
Yeah.
But anyway, I mean, so it's a stark picture, though. 2,275 locations have closed, and they're all over the country. And I guess one of the things that surprised me was after doing this and putting it on a map that I put up online, there are pharmacies all the way from the American Holdings in like Guam. And
we have Guam customers, actually.
Yeah, there are pharmacies that have closed all the way in Guam to Puerto Rico.
Mm-hmm.
And so, like, looking at the map, it's like, wow, that's like half the world.
It's wild, right?
See closings on.
Yeah.
It's a, I mean, there's not very many in the
Sure. Sure.
Pacific area, but like the continental U.S. is nuts, and like you go dive into Ohio, Michigan,
I was going to say,
Florida,
where
and
you,
New York.
yeah, is that where a lot of
That's where you see a lot of closures.
Okay.
And it's mainly chains, right?
That's a lot of where Rite Aid was, right?
Rite Aid was like the Michigan, Ohio area, some New York. Winn-Dixie also sold to
That's right.
Aldi, and
which
sold
is
all their
Florida
files and inventory to CVS Walgreens that were nearby. But they painted the color. They painted the state of Florida with closures because they just had so much market share there, at least by store count. I don't know if they actually had prescription count.
That's fair.
I mean, this is the other thing that like really upsets me when I do get into these, like when I do read in these debates where PBMs are like, no, it's fine. There's a ton of pharmacies still. Is that we're using locations as a proxy for market share, and that is not a fair judgment at all.
Okay.
Right? Like, by dollars of drugs dispensed, CVS, OptumRx, and Express Scripts mail order specialty pharmacies occupy like more than 60% of total volume.
Yeah, it's like 60 or something like that, I thought.
I don't know the exact number is off the top of my head, but it is
in specialty space for sure.
The specialty space is where revenue is.
Yeah.
Like, and so we're in the situation where little pharmacies and community pharmacies generally are dispensing all of the cheap stuff. And like the level of dishonesty that I see from PBMs in this space is just incredible. And like they say things that are technically true, but are very obviously concealing a significant fact. For example, Cigna is suing the Federal Trade Commission because they don't like the FTC's interim 6B study where they said that the PBMs are raising the prices of drugs and driving independent pharmacies out of business.
Okay.
That was the FTC's subtitle to their report. And Cigna doesn't like this. And so apparently Cigna, United, and CVS all took all of their data that they sent to the FTC and they sent it to a guy named Professor Dennis Carlton at the University of Chicago to do his own analysis of the data.
Okay.
And that's a heavily referenced. The guy published a report. It's carltonreport.org.
Okay.
It's got its own website. It's this big to-do. And Cigna referenced that report like 20, 30 times in their lawsuit against the FTC. But you read through that report, and first off, it's if that's a rigorous report, I don't want to have rigor in reports, is my frank statement. Because like it's like 17 pages of just like graphs with no context. Like there's a little bit of context.
Sure.
There's like a couple of footnotes, but like there's no methodology. There's no explanation of how this was determined. It's just 17 pages, I think 17 pages of just graphs of like, people say that independent pharmacy sucks, but like that like profit margins suck, but profit margins according to NCPA have gone up, but they truncate things in 2021.
Yeah, when COVID.
Anyone who's in pharmacy is like, oh wait, 2021, that's COVID vaccines.
Right. That was all vaccines. Yeah,
Pharmacies
100%.
were doing great.
Yes.
Because COVID vaccines made them a bunch of money across the board, right? But they truncate just at 2021, even though more recent data is available. And it's like, okay, gross margins go up a little bit and then they drop pretty substantially for the 2022 data, which is the most recent stuff that NCPA Digest has put out. So like that feels incredibly dishonest to just say,
pretty misleading.
COVID, see, pharmacy's doing great. COVID happened.
Yeah.
But then additionally, it's like we looked at a sample of data of what PBMs paid chain pharmacies and what PBMs paid independent pharmacies. And we paid independent pharmacies more than we paid chain pharmacies for the same drugs. But then you look at the actual definition of what they're looking at, and they specifically say looking at non-specialty brands and non-specialty generics.
Yeah. Yeah.
I mean, when I look at a pharmacy's revenue statement, and you guys probably see this at Pioneer too, if you ever look at the data, if you look at if you take just all of the transactions in a given month for a given pharmacy, you'll find that something like 7 to 15% of prescriptions the pharmacy is actually losing money on.
Yeah.
And so we're just rank ordering things from most profitable to least profitable, starting at the bottom. So least profitable, you get to 10%, and the pharmacy's losing money on every single one of those. You then take the least profitable prescriptions where they are actually earning marginal gross profit against their cost of goods. You got things where they're making a penny, 2 pennies, 3 pennies, $1, whatever. And it takes this is consistent across every pharmacy I've ever looked at. 10% you're losing money on takes you the next 50 to 60% of prescriptions to get back to break even. And then the last, 30-ish % of prescriptions is where all of the profit is. And if you look at that, 60+% of the profit is concentrated in 1% of the transactions, right? The pharmacies make money. I've described this as a slot machine before. Lots of people have, but pharmacies make money on 777 drugs. If we use that slot machine analogy.
Sure.
But what are those drugs? What are the items where pharmacies actually make money? They're all specialty generics.
Okay. Yeah.
And so if we're paying independent pharmacies more than chain pharmacies on non-specialty generics, well, then that's all of the two cherry stuff where you're losing money or you're just getting back to break even.
Yeah.
And so that just means you're not losing as much money as you would if they had paid you the same amount as a chain. But to actually earn profit to be able to pay your staff, you have to have those 777 specialty drugs. That's the way the PBMs have built the system. And why is that? Well, I mean, this is something that I think about a lot, but I think it's really just PBMs have built a system where if you dispense only specialty drugs, you make a ton of money. And if you dispense all of the other stuff, you lose money or maybe you break even, right? And so that's a really messed up incentive structure, right?
If you really think about incentives drive behavior with patients and how you take care of them, and people are humans 100%.
Yeah. I mean, people that operate pharmacies are not charities. They want to earn profit. And so what you're implicitly saying is that taking care of someone with HIV or rheumatoid arthritis or another specialty disease state is more valuable, so much more valuable that it is more valuable than everything else you do. Taking care of one person with that disease state is worth more than taking care of thousands of people with high blood pressure or diabetes, frankly. And so you, pharmacy, should, if you wanted to absolutely maximize your profit, the theoretical thing that you would do is just turn yourself into a specialty pharmacy that mails drugs and specifically only 777 specialty items, and that's all you dispense. And you would just say, you know what, all the rest of you people that I've built relationships with, you can go find another pharmacy because I need to take care of number one. That's how the incentive structure is set up, is you should take care of the 10 people that make you money and just tell everyone else to get lost. And that sounds terrible, but that's exactly what a mail order specialty pharmacy vertically integrated PBM is.
Yeah, that's what they built already.
They are a company that says, I will take care of the very, very profitable prescriptions, and everyone else can go find someone else. And all the rest of us are stuck sitting here as taking care of everyone else. And we just happen to get a small amount of leakage from the specialty game. That's messed up.
Yeah.
But that is what the way that pharmacies are paid. That's what the payment system tells you should do. You should be CVS specialty pharmacy. You should be OptumRx specialty pharmacy, or you should try to emulate their behavior, which is wrong. My oath as a pharmacist says that my job is to take care of all people that walk through my doors, all people, and to advocate for all people who need medicines, not just the ones who have diseases where the PBM has decided that that's where we'll make money.
Yeah, no, it's like what you just said is the reason why there's so much friction in the system at the moment, right? Like, you literally describe the structure of the financial system and send it in such a way where it does not align at all with, like, usually most people I talk to in this profession, their value system. It's just not.
And it doesn't align with good public policy either, right? Like,
yeah, that's fair.
You should not want a system, like, if you're a member of the general public, you should not want your pharmacist to care which drugs you get from a financial standpoint. You should want them to care about you as a person who needs help getting their medicines and making sure it's the best medicine for you, not which medicine is the best from a financial standpoint for me as a pharmacist.
From a P&L perspective, and then that's what I'll cater
but
to,
like,
I guess is the word.
The system has been built in such a way that, like, pharmacists that operate a pharmacy on their own effectively have no choice but to care about what's best for their bottom line. Because, like, if you only dispense those 7% of drugs where you're losing money and those 50% where it brings you back to break even, well, then you're breaking even, like, on just cost of goods. You're not paying your staff.
Yeah, that's not labor.
Rent.
That's not, it's not SG&A. Right? It's not any of that stuff. Yep.
And so you're sitting there just breaking even on drug product itself, let alone all of the other costs that go into running the place. And you're not going to be in a position to be able to invest in any additional services. And so, like, that to me is why, in large measure, there are so many pharmacies that are closing, is just that the incentive system is so screwed up, where we pay for specialty pharmacy and we pay peanuts to everybody else. Mm-hmm. But it's a great system if you're the PBM. Also,
what you described and what you talked about with what you saw as far as, like, openings go. You said, we had about a net 3%, and a lot of the openings were leaned towards what you just described, the financial system you just described.
I mean, additionally, like, more than half of all of the gross margin in pharmacies earned in 340B. So you should also want to be a 340B covered entity or a contract pharmacy with a 340B covered entity, which is, again, what the PBMs are. The PBM specialty pharmacies are, by and large, 340B covered entity contract pharmacies.
Yeah.
And they dispense an enormous amount of drug through the 340B program. And so, like, that's, again, what you should want to be, because you can buy the crazy expensive drugs at a 30% discount and sell it at the same price.
Yeah. Yep.
But like, going back to my work at AELP, like, this is me realizing that, a lot of the problems that we face in this industry are the direct result of choices the federal government has made. I mean, when you take into account all of the federal government programs that pay for drugs, the typical pharmacy derives at least 60%, if not 70 to 90% of their revenue from federal programs, and sometimes state programs as well, like Medicaid. But you take Medicaid, Medicare, TRICARE, federal employees, the Affordable Care Act, and 340B as well. Like, that's an enormous fraction of total payments and also of margin in pharmacy. So our profession as pharmacists is very much determined by how the federal government chooses to pay for drugs. And as it stands, we choose to pay for drugs in 17 different ways for 17 different programs at price points that are set by PBMs that different government agencies contract, and that are set in primarily a way that is set to benefit those contractors
who administer the program, right? Yeah,
exactly.
I was talking about that the other day with somebody else. It's like, there's just, you basically, and I'm not saying anything like profound there, but there's literally no minimum set for like what coverage of cost or whatever metric you want to talk about, whether it's NADAC plus, whatever it is, like whatever metric you want to talk about. There's no dictation handed down from the federal government to these companies to go, look, you're administering literally a federal program. Do it how you want. See ya.
There are limitations. You have to do this, that, and the other. You have to have a network of pharmacies. You have to do this, but
but not for the reimbursement model. Like really,
it's very much just free market, right?
Yeah.
But it's freedom for who?
Yeah, and that probably works when you have 20 players, 30 players, right?
Right.
It's harder to make that work, I think, because incentives just become incentives. It drives behavior with 3.
Right.
Right.
Yeah. And like the 3, and maybe you throw in the next tier 3, but like between them, they control an enormous fraction of those federal programs, and so. And yeah, to your point, there is no minimum.
Right. There's not.
Pharmacies do get paid regularly 47 cents to dispense a prescription.
Right.
72 cents.
A 2-cent dispensing fee, right?
And a 0-cent dispense fee, and just, we'll pay you 47 cents for the pills in the bottle. We know they cost you 15 cents. Yeah. Have fun.
Yeah.
Oh, by the way, we charge a 30-cent admin fee for every claim you submit.
Right. Yeah. We know it cost you about $12 to do it, but here you go. Like, it's just a weird, like that's a weird program to me, even from a federal government perspective. Like, I don't know.
Yeah. I mean, I see some degree of hope in that everyone on Capitol Hill wants to do something about PBMs.
Yeah, that's a good segue. What can we be optimistic about then?
I mean, everyone wants to do something about PBMs. The question at this point is not whether something will come out of Congress about PBMs. Okay. It's whether it's something that's helpful.
Oh, all right.
To me, that's the question, right? Like, if we pass just a PBM bill, if it's only about delinking of PBM compensation from list prices, that is an enormous missed opportunity. If it doesn't say something, like if whatever bill comes out of the next few months, and I think that there will be a bill by the end of the year.
Okay.
Before the new Congress gets.
Is that do you think it's that? Is it 1996 or? I
don't think. I don't know. I hope 9096 in some form gets into whatever legislative package actually goes. But yeah, the Pharmacist Fight Back Act is like, it would make a humongous difference to this, what I will describe as a crisis of pharmacies closing because of no minimum, because of no price regulation, just do whatever you want, pay people whatever you want.
And when you've accumulated all the power, you can do that, right? That's
right.
Yeah.
Yeah. HR 9096 would just set everything to NADAC plus a professional dispense fee, the same way that Medicaid fee-for-service works, which is it's a better way of doing things.
Yeah.
It pays pharmacists for the service of dispensing rather than for the commodity of amlodipine or the commodity of imatinib, which is like, I want to be a service provider as a pharmacist who gives people access to medicine. I want to earn profit for service to people, for the service of delivery of prescriptions, whether that be in person or
right.
frankly to their house. I'm not particularly interested per se in earning margin on drug markup.
Right. Buying X, system, selling it for Y, that kind of,
I mean, that system turns a bunch of doctors of pharmacy into commodities bookies. And that to me is just a total waste of the education that I've earned, because the education I obtained in pharmacy school at St. Louis College of Pharmacy had zero to do with commodities trading.
You didn't get a lot of commodities trading school at your, not your farm program?
There was no class on
I think you just missed
commodities
the class.
trading and real-time bidding, and
you must have didn't sign up for it, Benjamin.
I guess I signed up for the wrong coursework.
Yeah, I know. I hear you. I know. Yeah.
I mean, commodities trading is I suppose, useful service, but it is not why anyone went to pharmacy school, because they want to be a commodities trader.
For sure. Yeah, no, not even a little bit. Yeah, I'm with you. I respect that position, because you're basically you're going back to aligning incentives with what you signed up for
with
originally. Being
a professional,
right, with what you signed up for originally. So that makes sense. Nobody's looking at that going, I'm afraid of all this margin I'm making. It's just not there anymore to begin with. So
no, I mean, there are little places where you find a 777 and you celebrate for a day, and then you pray that you find another one before the doors close.
Well,
right.
Okay. So anything else to glean? So you talked about a little bit of, I mean, we're in the middle of it. Are we in the middle of open enrollment, or is it close?
No,
it's really
it's
close. Yeah, it's next month.
October 15th. My life will be on fire.
What are you telling pharmacies to do with that coming up? Like, what's kind of your take or your?
I mean, first of all, you should be an agent. You should be getting licensed if you're not already.
Mm-hmm. I know people who are. Yeah, some people are leaning into that.
Yeah. There's a surprising number who already are. There are other companies that are in this same insurance agency space. It was not where we started, but it's where we landed as one of our services. But anyway, I mean, that's one thing. And then two, you should be having conversations with as many people as you can, because this open enrollment, if people don't change plans, they're making a mistake. Basically every single Medicare patient should be outbidding basically what plan they should be on, because there are so many changes to the Medicare Part D program for 2025. There's a new out-of-pocket maximum. Premiums are going through the roof.
What's the best way? What's the best resource for pharmacies to get educated on that? A lot of people are going to listen to this, I think, that mainly because it's you, but what's the best way? I know NCPA is a resource too, but what's the best way to probably get yourself spun up? You have an October 15 deadline to when you're going to start having these conversations.
I think the first thing that I would do is sign up for the CMS's webinars.
Yeah.
They're holding a series of 10 webinars about the so-called prescription payment program.
Yeah, we'll put that in the show notes too then.
That's probably the first thing that I would do, is sign up for that, because they get into a lot of the changes with it. But I mean, the smart money says that there's something like 60 to 70% of people will change plans this year just because of all the changes. And so so that means there's an opportunity to help your customers to choose plans that are beneficial to them and that allow your pharmacy to stay open.
Right. Yep.
And they need help. The context of how many options there are to choose from And Salt Lake's relatively tame. I mean, Los
37.
Angeles, you've got like 130 different options.
Do you imagine? Like, if I wanted to buy a truck tomorrow, I wouldn't have 130 options to buy a truck tomorrow. You know what I mean? Like, there's just
Right.
nothing you can buy with that many options except this, like that I know of anyway.
Right. Unless you're like saying, okay, I'm not only going to look at like F-150s, but I'm going to look at like every trim level.
Even then, I think, like, I don't know. Like,
there may not even be that many
truck.
choices there.
Yeah.
But yeah, anyway. But yeah, it's been a great time talking with you.
Yeah, no. I think
I don't know if we got to everything or not, but
I don't know if we did or not. We ran longer than we normally do, but man, I think I just wanted to understand your perspective, let everybody else hear it too. Along with, like, we'll put in the show notes kind of all the stuff we just talked about to, like, have an easy link for someone to go hit, whether it's on YouTube or any other places. Last thing, I don't let anybody get out of here without this, and maybe Brandon didn't get to prep you for this, but so this will be cold. The segment's called Prescribables. I basically just ask you, what are you reading, watching, listening to, or what are you into right now that other people should be or would be?
Huh. Okay.
It could be fun. It could be work. It don't matter.
I've been watching like all the back episodes of all of the Star Wars shows on Disney Plus at the moment.
Oh, really? All right.
Yeah, that's been a lot of what I've been doing. The Bad Batch is my current show that I've been watching.
That is my daughter's like absolute favorite. And she's not even a big Star Wars junkie, but one of her favorite series. She's actually in college for animation, so she just loves it on different levels too that I don't understand, but she loves that show. That's cool.
Yeah. It's fun. It's a, just tune out everything and just watch a show for me, but that's what I've been watching.
Nice.
I guess the other thing I've been reading, Discworld by Terry Pratchett. It's,
what's that?
He passed away a few years ago. It's a series of books that takes place on a world that is literally a flat world that sits on the back of four elephants that sit on top of a turtle that floats through space.
All right.
It is a very silly, very funny series of books, and you can. It's really well done where you can basically get into it with any of the books. There's like 50 books or something, but you can basically just pick up any of them and just start reading, and it'll work out. I started with like book 32 before I knew that there was a bunch of other books.
A bunch of other ones.
It's called Unseen Academicals. And it's about these wizards who run a university and have to form a soccer team or they lose their endowment. Was
that inscripted in the end, like the revocable trust?
One of their donors from like 200 years ago or something, before this book takes place, said that they have to field a soccer team every 10 years or they lose like the entire endowment. It goes to his like seventh uncle, like great nephew or something. Basically it would be like Jolley's Pharmacy going to Mark Bivins. But it's hilarious. Like it just parodies all of these like bits about wizards and about like a magical school, and it's very, very funny.
And there's a will involved. Right.
And I don't know.
That's cool.
And they end up reinventing the sport of soccer. Football, the ball.
Sorry. Yeah, I don't know.
It's very silly.
Anyway, I say that nowadays.
I recommend it.
That's good.
Fun to read.
Mine, I think, is I'm in my like documentary phase of my life. I don't know. I was telling everybody now at this point where I'm like, I think I'm graduating to like get off my lawn later or whatever. But like, I'm in my documentary phase of my life. But I'm watching one on Netflix about the Cold War, kind of like just how it started, what what happened, how much famine went on in like Russia with it, things like that. So it's
Mhm.
really good. A lot of things I didn't know. I was not a history kid when I was younger. I just was like not interested. If it was Teenage Mutant Turtles, I was in. But
There we go.
Not.
Yeah.
I wasn't. So, but that's good. I think it's called Turning Point. It's one of the Turning Point series ones, I think, is what it is. But it's a good one. It's a good one. So,
Cool.
But not everybody's going to huddle around you watching that one, though. Everyone's going to be like,
Right.
Yeah, everyone's going to be like, oh, cool, depressing. See ya. Like,
You want an investment opportunity? There's a documentary being filmed right now about pharmacy and the screwed up state of it. Yeah, called Pharmacy.
Okay.
Yeah.
All right. I think that's a scoop. Is that a scoop that we got?
I think they're looking for investors still. So
okay. We'll check them out.
Yeah, but yeah, I've seen their sizzle reel. It looks really good.
Okay.
So
I might
hopefully
have seen that. I might have seen that one. I was wondering what ever happened.
They haven't finished the documentary yet. They've just done like little like short clips because they're still working on it. But yeah.
All right, I'll take a look. All right, man. Well,
Anyway.
Mr. Jolley, thanks for being on. Really appreciate what you do for the profession.
Thank you.
I work in it too as a vendor, but we need super smart people like you and others talking to leaders to support this industry and take it back a little bit, take control a little bit. But
for sure,
appreciate you being on. I know it was longer than normal, but I appreciate you bearing with me.
Yeah, well, it's fun. It's always fun to ramble about things.
Good. It's good.
Good talking with you, Mark.
All right, man. Talk to you later.
Bye.
Bye, everybody.